First, thank you for two very interesting presentations. And I have a comment on the population health that you mentioned, and that is that it is a field that is building. The term wasn't even in existence when the Robert Wood Johnson Foundation really set up the Health and Society Scholars Program 10 years ago. That program is a postdoc, for those of you who don't know, that takes people from any discipline related to health, medicine, nursing, anthropology, economics, et cetera, and people do a postdoc where they cross-train. And they cross-train in a group of different people from themselves. But if you've been in the lab all the time, suddenly you need to learn to be out in the community. And enough of these scholars have now emerged, this is a 10-year-old program, into the professional world where they're beginning to have an impact on education and on health professions education. They're certainly having an impact on the language and on our understanding. Clearly, they need to do more, and maybe RWJ and the universities that are associated with this need to do more to communicate what the program is. But I think it is one of our hopes in stretching people out of their disciplinary silos into the community and into interdisciplinary work.
I actually have a question for Jeff before we start taking questions. Jeff, could you give us an overview of how you actually use hotspotting for to ensure some sort of care coordination for the patients that you see in Camden?
Sure. So we got pretty inspired by people who were disciples of Bratton, who came when our police department was falling apart for the 13th time. So about 8 years ago, a whole bunch of Bratton's folks came, and the brilliance of what Bratton had done with data was not just that they made cool maps and showed patterns of crime, but he built a whole managerial system to support that. So he decided that the precincts would become the denominator, the unit of accountability, and he decided the precinct captains would become the accountable managers. And in healthcare, we've never really decided that. I mean, it's really the key to population health is the denominator. And then who's the accountable manager responsible for that denominator? So, so the precinct captains had to stand up in front of their laterals, so the other precinct captains, every week with Bratton putting them on the hot seat, standing in front of their data and explain that week what are they doing to redeploy their officers to respond in real time to the patterns of crime. So it wasn't the ComStat, it was the managerial system to hold people accountable to what the data was showing. So we've tried to figure that out and translate that into Camden. And so for us, hotspotting is looking for outliers. It's responding in real time to the patterns in healthcare. And we've done that in a couple of different ways. It's really a segmentation problem. You can do it geographically. So we have found buildings that are buildings where all of the expensive patients get collected. And that's not just here in Camden, it's all over the country. We've mapped a bunch of rural states, we've mapped suburban areas, we've graphed and mapped employee data sets. I mean, there are crazy geographic patterns in every data set we've looked at where people get collected up into specific geographic patterns. So that's one example, but for us, hotspotting is also just taking a large data set, rank ordering on number of inpatient visits from the most to the least, and going out and meeting the 10 highest utilizers is a form of hotspotting on complexity. So that's a utilization segmentation rather than a geographic segmentation. You know, in all of our human systems, in education, in criminal justice, and in healthcare, we have built systems that deal with the averages, but we haven't built systems that deal with the outliers. So, you know, 1 or 2 kids in every classroom are the ones driving a lot of the discipline. In a school, there are a few families that are in the principal's office all the time, and those kids and families may have different learning styles, they may have adaptive and coping problems, and the school, the police department, and the healthcare system don't pivot day by day to the unique needs of those outliers. So, and all of us will probably become outliers in healthcare at some point, or our family member will become an outlier. So for us, hotspotting is how do you use data in a way to surveil the data and target services, and then how do you build focused factories, highly reliable delivery systems that deliver services to each of those segments within the data.
Sarah, this is a question for you. I'm a social worker, and I've been to Alaska many times to meet with social workers. I don't think there's anywhere in the country that social work is harder than it is in Alaska. I mean, the distance, the barriers that you've talked about. Do you actually work with any of those social workers in your consortium?
We do. We also have patient navigators. A lot of times social workers are not where the patients are either. I think that our state is kind of morphing, and we may be sort of ahead of the curve just a little bit on gathering up all of the resources that are available that are in disparate organizations in the government and all different areas, public health, and really trying to connect them together to pool resources in a coordinated way. I feel like we're on the tipping point. I think we'll see it in the next 10 years. So that collaboration is beginning to happen. So we do have social workers, we do have patient navigators that sometimes operate as social workers, and their level of interaction with the community is dependent on the community as well. So a lot of times we find that there's also a cultural barrier. So if a social worker or a public health person or even a patient navigator to some extent isn't from their region, there's a resistance to accept that type of service. And so we're really trying to remove some of those barriers to provide that care. Our whole goal is care closer to home, and part of that is involved in the cultural education of all of our providers as well.
I want to thank you all for bringing us two wonderfully contrasting models in the community. One focused on that 1% and the retraining of folks who have been brought up in more traditional roles, and the other one, a very rural model where the expansion is on the side of indigenous and local people. And Sarah, I know that you've expanded beyond community health workers, and given our discussions today, could you say a little bit about the expansion to community mental health workers and dental associates in your model?
Yeah, I didn't have all the time in the world, but I can certainly address that. So at the base level, we have, each village has a community health aid provider practitioner, various levels of training. Some of those communities also have a dental health aid, so it's expanded to a dental health aid program as well as a behavioral health aid program. It worked very well for community health aides. Those dental health aides and behavioral health aides are not as broadly deployed as our community health aid. More frequently, they'll be trained and located in one of the hubs, and they'll serve the 26 or depending villages in the surrounding area and travel. But that's a model that works very, very well. Our dental health aides can do simple extractions. They can do lots of preventative health care fillings, and then they use a lot of the telemedicine equipment that's in that area. We have dental cameras to assess if the patient can be treated there where the dental health aid is, or if they need to travel in to receive that care in a hub or potentially a surgery in our tertiary care setting.
Also, oh, go ahead. From my, Pat Walker, from my experience when I was at the University of Colorado, because we had outreach into Alaska, but we also had bordering Indian health. Could you talk a little bit about some of the challenges of the Native American structures and working within villages? Are you working within those villages? And because we found just it was a different kind of challenge. Not labeling it, I'm just wondering if you might speak to that. And then we had some challenges around acculturation after we brought individuals out, trying to get them back into those communities. Could you just talk about the culture and acculturation issue?
Uh, we have interesting cultural issues. We have tribal politics as well. So, the consortium that I work for actually works for 30 different tribal health organizations. And I'd say that that collaboration has improved tremendously. There's much more health systems think than there was previously. I've been there 8.5 years and I've seen a dramatic change in that. And so that's a very positive thing. I think part of that is our providers are becoming less what we call ANMC centric and recognizing that they're there to serve all of these this population, that the population isn't there to come to them. And so we're starting to see that kind of transition in the cultural awareness. And that starts from leadership. So that is an interesting, different kind of cultural and political barrier that's starting to sway in the very, I think, favor of patient care. The other question that you asked was, when we train people, do they leave? The answer is yes. They don't just leave; we burn them out. So what's happened and this is anecdotal, I don't have numbers. I'm telemedicine, I'm not our community health aid training program, but I can tell you that our community health aides are tapped out. So, they're the only person in that community that sees all of the healthcare issues, including serious traumas, which can be very, very difficult because these might be a family member that they're treating. It could be, they know these folks very well. So we've loaded them so full with information that they burn out pretty quickly. So they do leave in that regard. They also may come into Anchorage and train in Anchorage or a different type of hub. We have had hubs in other areas as well that are more urban. And they stay. They don't want to go back to that area. I say that's more rare. There is a commitment on the tribal, on the community health aides end to have some commitment to the training program that they started, and they are hired by that community to provide the service. But people are people, and they will do what they'll do. But we're having less of an issue with that. I think the more resources we have to assist them so that they're not the only provider on call 24/7, the easier it is for them to provide that type of service, less opportunity to burn out.
So this is a question for Jeffrey. So you're dealing with prevention, tertiary prevention. Who's dealing with the rest of the prevention in Camden? We live across in Philadelphia, and we would like to see prevention right from the bottoms up, not only tertiary. So are you working with anybody on that? Are there other organizations?
We have an AHEC in Camden, Camden AHEC, and there are other initiatives at the community level. So, I have found care coordination for the sickest patients to be one of the most complex problems I've ever touched. And as many years as we've been doing it, we're still not great at it, nor have we figured it all out. So, I've needed to say no to all the other stuff and let other organizations pick that up. Look, Camden's a mess. There's not enough money, right? There's not enough money for primary prevention. Frankly, let's be totally clear, primary prevention often doesn't have an ROI. Secondary prevention's ROI is 10, 15, 20 years away. And the ROI world I live in is quarter by quarter. Insurance company executives receive bonuses every quarter for what they, for their targets. So I don't have the luxury of playing for savings years and years out. I need to be able to show that we generate savings sooner, particularly in an ACO model. The only way to generate savings quarter over quarter is care coordination. Only thing that'll generate savings that quickly.
Can you speak to some of the outcomes?
Yeah, we just launched a randomized controlled trial. So for the stats, biostats and epi people know this, but Whenever you take an extreme group of patients, if you take 100 of them and you do absolutely nothing to them, they will regress by about 20 to 30% in their cost and their utilization. So if you do a pre-post, it's kind of meaningless. And trying to find matches to people who've gone 113 times in a year is kind of hard. So statistically, you can find artificial control groups, but that's not a very good way of doing it. So we just launched a randomized control trial last month. So we're going to randomize, we're randomizing at the bedside. So we go in and engage patient consent and hit the random button. So we're going to randomize 400 into the intervention, 400 into the control. It really brings up a broader issue, which is there is not enough funding for really good population health randomized interventions, and very few in the literature for outliers. And they're really hard to set up. An NIH grant doesn't pay for the clinical team. The private foundation grant doesn't pay for the research. So, I mean, we've got the craziest jigsaw cobbled together funding for this thing to be able to do it. Yep.
Well, Jeff, thanks for this talk. And I think this challenges really some of the fundamental concepts that we cherish so much in our curricula. You make a plea for complexity instead of reductionism. And most of us, we try to go away from complexity. So we should learn to embrace complexity. I think for future health professionals, it's a very important issue at all levels of the care process. You were talking about generalism, whilst today we just focus on to know almost everything about almost nothing with subspecialization. So that's also a paradigm switch. You talked about chaos, and unpredictability versus order. I think these are all fundamental issues that we will have to introduce also in our educational process if we want to prepare our generations for the future. And of course, in no exam on statistics, you can answer that an average is nonsense and that the outliers are the essence of the story. But I think this is really, I think, at the meta level, very important to really look critically at what the underlying concepts of our actual curricula are and where we prepare. And when I come then to organizational level, I see that the bureaucratic hierarchical approach is certainly not valid in such a context, and we have to go for more complex adaptive systems approaches where people really try to start from the reality they are confronted with and build up innovative ways to deal with that. So thanks for that paradigm challenge.
And I 100% agree. And there's a lovely book that I think really does the best job I've seen laying all this out, which is by E.O. Wilson called Consilience. And he makes the case that in our understanding of biology now, we're grinding to a halt in our reductionism, and that, you know, we'll never cure cancer if you don't have mathematicians teaming up with computer scientists, teaming up with biologists and chemists. So I don't think it's just population health where we've ground to a halt in reductionism. I think there are a whole variety of fields where that's true. And academia just doesn't even have the structures to begin to pull people together in the ways that need to be pulled together. So thank you. So consilience is my favorite word for what you're describing. You know, population health is a consilient field.
Thank you. I'm Sarah. Yes, I would like to address my question to you, Sarah Freeman. And I understand there are several freestanding community-based birth centers in Alaska. And do you have any idea if they've made an impact on the healthcare there?
Our system does not have freestanding birth centers. Our system does not have freestanding birth centers, so I'm not able to speak to that. I'm sorry.
I'm sorry, my ears are not great. Could you say that
I
again?
said our system doesn't have freestanding birth centers.
So these would probably be birth centers that were set up to serve the middle class? Because I think some of them are serving Native Alaskans. But
usually they're part of the health system of the tribal health system. So we do have some, like in our hubs, we do some birthing. Actually, culturally, it's very important for the community to be around the birth for the Alaska Native population. And so we've broken that paradigm as we actually ship high-risk pregnant women to Anchorage and have them live there for the last few months of their pregnancy oftentimes.
I had an experience with the Sisseton Wahpeton Sioux. Was an expert for Phil Lee when he was Assistant Secretary for Health. And the women in Sisseton, the Native American women, really wanted a birth center which they would make culturally accurate and appropriate and so forth. But in Sisseton there is, at the time at least, there was one hospital. This was in the 90s. And if a birth center had been established, it would have taken so much of the maternity business out of the hospital that the hospital probably would have imploded. And so they didn't do the birth center there. But it's so often comes down to the economics of the healthcare system, doesn't it?
In some regards, I think that's true. We have one system that is getting set up in the Bethel area, which is one of our larger areas. It serves a great majority of the Alaska Native population. But, you know, pediatrics and OB are two really difficult things to treat in Alaska. Our providers, if I can kind of give you one plug for what we need, is we need family practice docs that can practice in the ER, deliver babies, and also deal with pediatrics. Because oftentimes those areas, they wind up shipping those patients out of their community for those services because they're not very comfortable. The family practice doctors in the hubs aren't comfortable treating those patients. But going back to the birthing center, there's one that is going up right now to service a large volume of our women who are impending delivery. But oftentimes they will be shipped to Anchorage, or should I say shipped, or on flights to Anchorage in order to, if there's something that goes wrong, it just takes too long to get those patients the care they need. So we're reluctant to not have them sent.
Yeah, I think that some of them at least are accredited, and the accreditation takes that into consideration, transfer times and things like that. So I would like to talk to you further about this at another time.
I think, Rick, was your hand up?
My question's for Jeff. Our hospitals are working really hard to keep people out of the emergency room and out of the hospital if they don't have insurance. They're not working, it just seems like maybe they're not working as hard if they do have insurance. And so my questions are you partially funded by the hospitals, and do you look at, is this segmented out by insurance, or are you treating everybody whether they have insurance or not?
Question. So I think it took me a long time to realize why we were getting away with what we were getting away with. Essentially, what we were doing is sort of, it'd be like going to Kmart, Walmart, and Target, getting all of their business intelligence, all their customer data, combining into one data set, and then getting rid of their customers, right? Yeah. So the only reason that we're getting away with this is that we've got the adverse market share that no one wants. So, you know, when you get to dual eligibles or even just Medicaid, who are the outliers, they drive people crazy. You know, the systems just don't want them. Like the lengths of stay are too long, they cause friction in the system. So, you know, we thought we were doing something altruistic, and then they'd be like, here, take another one. No, here, have another one, and another one. And pretty quickly, we got just overrun by referrals. And so I think it's because all three hospitals are suburban facing, and their goal is to get well-insured, commercially insured patients in, and the folks we're dealing with are the adverse market share. It's the opposite of the monopoly. It's the folks that you don't want, you know. For our intervention right now, when we used to pick up uninsured patients, we stopped only because we're funded by a CMMI innovation grant, and we got sort of tied up in knots with how do you show savings if they don't cost anything. So right now we're exclusively there's more patients than we can touch. So for right now, we're just focused on the Medicaid, Medicare folks, not the uninsured.
Linda Kasser, representing Association of Schools and Colleges of Optometry. My question is for Sandra. I was wondering if you've had an opportunity to involve trainees in your consortium. Certainly your work represents a wonderful example of community-based healthcare delivery, integration of technology, and interprofessional collaborative care.
So we do have trainees. We actually we have a WWAMI program. It's a conglomeration of Washington, Wyoming, Alaska, Montana, and Idaho. So we have students from there coming through our organization, and oftentimes they'll go to our other tribal health partners in more rural areas. We have visiting fellows quite often. We have visiting nations quite often, looking at our telemedicine program and how we're delivering care in rural settings. And it's very applicable to their setting. It's actually applicable to urban settings as well. It's just that people kind of don't think that way as much, and I think that's changing. We have pharmacy students as well. We have lots of different types of trainees that come through, less for training, more for seeing what we're doing and seeing what they can maybe reproduce in their area. There's a pharmacy residency program there. There's a medical residency program there for pediatrics. It's more focused on rural areas. We do field clinics as well, so we send our providers out and our residents so that they actually can go and do field clinics to see what resources those patients truly have available to them. So.
Bjork from the Training for Health Equity Network. This is to Jeffrey. Following up on Jan's question, I think this highlights the failure of both education and the health system. I would love to hear your perspective on what you have learned and how should that be reflected in a new vision of a health education system or for health professional education.
I think we should have a broader discussion about what the pedagogy of medical education is, and I think this is not as true for nursing education, but partly true, which is the history of medical education is it's not a liberal critical thought. It's a much older tradition. So somehow, like, the Enlightenment completely bypassed the medical profession. So, it's a Greek tradition, and there are maybe 10 or 20% of doctors who are truly scientists, truly applying, the scientific method in a critical way, and the rest of us are doing what we're told. We march up in a hierarchy, and in a hierarchy, you keep your mouth shut. And it's really very equivalent to like being a bricklayer, where you're a journeyman bricklayer, or you're a priest, and you follow the authority figures around you. You parrot their methods and the way they do things, and if you do that well, then you'll move up the order. So that's not liberal critical thinking, right? So I don't think we're gonna, the Hopkins model came along in the Flexner report and tried to blow this apart, and sort of did a little bit. Like, we got the scientific method in there, but there's like all whole other parts of the Enlightenment that somehow never got into the model. So that's a pretty deep critique, right? I don't know what to do with that, right? You guys figure that one out.
I wanted to reflect on Jeffrey's comment about the role of data people in the success of what you're doing. And I think in our technology discussions earlier, we haven't talked about integrating people with these kinds of technological skills and how important they are to the work of healthcare now. This message came home to me last fall when I was teaching a course to DNP students, and I had a young man in my course who had a college education and had completed our accelerated nursing program, and now he was in a DNP program, but he had brokered a role for himself in our CTSI because although he was not formally trained in computer science, he was a real data guru. And when the course started and we were talking about interprofessional partnerships, it was very clinically oriented. And he said, there is no place for me in this course because what I do is very different than the clinical world you're talking about. And I said to him that your role is to figure out how we change the course to include you in what you do. And it led to very powerful discussion over the course of the semester about his role and our need to flex our thinking to include new players. So I really appreciated your comment about the role of needing these kinds of generalist data people.
Way to learn that is experiential learning, which is to be given a really messy unstructured data set and have to sit down and work through it. And biostats and epi curriculums don't do that. And I think they really teach you the wrong way to approach the data set, which is you get lost in like a detail and you don't understand what you're even looking at. So absolutely.
I have a question regarding that. When is the best time along the education pathway to introduce this approach to patient management?
I don't know how we're going to fix med school curriculum. I just don't understand how in the world we're going to do it. So I'm focused on before they get to med school. I mean, it's a power structure, and it's a very hierarchical power structure. It's got a lot of power, money, and influence. And I don't, I know there was discussion earlier around, how to shift complex adaptive systems. Like, it's a shaky three-legged stool, and if you succeed, you'll make the stool topple over, right? I mean, if you genuinely turned out a different kind of physician, they wouldn't populate the system as it currently exists. The whole financial model of academic health centers is totally unstable and will collapse. So I don't know, I don't know how you break that thing apart. I mean, it's their bonds will collapse. Their bonds are underwritten by state governments and local governments. I mean, it's a pretty big thing to break apart. It's been fed by the Hill-Burton Act. It's been fed by Medicaid, Medicare, GME dollars, by dish funds. Like, it's a big thing it's got a pain point coming. And maybe you just let it collapse and then you pick up the pieces and you have enough. Most complex adaptive systems don't change. They go through a state change, which means they go from here to here, and then the ashes, you build enough new models that becomes the new model later. So I don't even know that we need to talk about how to fix the ones. We need to talk about what will a new model look like, get enough of those in place so that you've got some seeds to grow back when the thing falls apart. So.
I hope this isn't too personal a question for both of you, but we talk all the time about how we attract very innovative, talented health professionals to areas that can be quite difficult. And Jeffrey, I think you said you've been in Camden about 15 years, and I don't know how long you've been there, Sarah, but what brought you to those areas, if that's not too personal a question?
Well, I came from San Diego. I was trained at UCSF, and so great weather to a beautiful spot that sometimes doesn't have the greatest weather. Actually, it was my husband, is a pilot for Alaska Airlines, that brought me there. But the reason that I chose the tribal health system is I actually was trained did my residency at Kaiser Permanente, and the model is very similar. They're very focused on population health. They're focused, the providers are all hired and work for the same organization. That it's a very similar model. My background is more in quality improvement, and I actually did business intelligence for anti-HC before I moved into telemedicine. But one of the things that we have a struggle with hiring providers, obviously, and we found that we've had to increase the pay rate tremendously in order to keep them and bring them on board. Most of our providers are very, very, very dedicated to the patients that they serve. And there's a familial feel amongst all of our tribal health organizations and providers and nursing staff and all of the interdisciplinary staff. And that is what really keeps people there.
I was hiding from the American healthcare system, and Camden, New Jersey is a really good place to hide. And around the country, we've found a lot of, malcontents and disgruntles are that are sort of off the edges of the system. A lot of our work's frankly modeled on the NUCA system up in Alaska. And, at the edges of a complex system are where the most interesting things happen, and it's where the power structure doesn't lock the place down as much. So a place like Camden, you can get a lot more done. A place like Alaska. So all the fun folks that we're collaborating with around the country are all sort of off the grid and running under the radar. There's plenty of them out there, but a lot of them are pretty frustrated, and they're kind of refugees from academic places. So.
Any more questions? Any more hands? Great. I'd like to thank Jeffrey and Sarah for their presentations today. I know it's tough presenting at 4:30 in the afternoon, but I have to say it was very stimulating discussion, and thank you very much for your attention. I saw everyone so well engaged. Thank you.